Hello and welcome to the Back to Health series presented by Customizedrelief. My name is Curtis Beall. I'm one of the providers here, and I'm joined today, as I'll be joined every day, by Dr. Christopher Roberts, our Chief Medical Officer here at Customizedrelief. And we're excited to bring our first of many talks here today with you all. It is on a topic that's very special and close to Dr. Roberts. I know that from talking to him, kind of what kicked off his journey into functional and integrative medicine, and that's on urinary incontinence. And he can maybe tell you more about that and his story on that. But first and foremost, I really just kind of will let you take the floor and kind of tell us to start off kind of what are the differences or different kinds of urinary incontinence.
Good question. I've been in practice now for about 30 years, and I tell my patients that God forayed me into integrative medicine, and it really has enhanced what we do in practice in individualizing care with patients. What's interesting is that with incontinence, again, I learned that even before I did my fellowship in integrative medicine, that incontinence is not just I leak urine. There are different types of leakage, and they're treated typically very differently. The classic one that patients think about is stress urinary incontinence, and that's where typically ladies, guys can have this too, but typically ladies will leak urine when they cough, sneeze, laugh, jump. Again, anything that increases pressure in the abdomen can lead to a loss of urine. Usually it's small amounts. Most ladies will have to wear a thin mini pad, sometimes thicker if they have multiple episodes during the day. And that one is one that we'll talk a little bit about, is classically treated today, even surgically. Now we're going to talk about some really conservative options that don't include that, but that's the surgical one. The second one, which it can be a really devastating one, is one called urgency incontinence or urge incontinence. This is where a patient will have an urge to go to the bathroom and they can't make it there in time. This is really common at nighttime, where patients will get an urgency because their bladder fills up as they're sleeping at nighttime. They're trying to get up out of bed, rapidly get to the bathroom, and they will sort of leak on the way. The volume of leakage is much higher with this kind of incontinence, which is usually why these patients will have to wear like a Depends diaper or some kind of a diaper, not always. But again, very difficult, and there are really not great surgeries to treat that one. I used to do a sacral stimulator implant. The problem is, decent results, but you have to change batteries out on these people. The leads would move. Again, it's not the panacea. A lot of patients will have mixed incontinence, and that's where they have urgency and stress incontinence. And what's interesting is that, again, I mentioned that stress incontinence oftentimes is treated with surgery. A lot of patients after surgery might develop urgency incontinence after having an incontinence surgery for stress urinary incontinence. And so again, what we're going to kind of talk about today is how can we avoid surgery if possible, because we have conservative options that, again, we've been doing now in our clinic for the last 12 years that are very effective for treating both. The last one is called overflow incontinence, and this one you have to be really careful for, and especially in the elderly patient, and in particular, especially patients who've had stroke or MS or neurologic disorders, because overflow basically is that patients can't get an urgency and they're not getting a normal reflex contraction to empty their bladder. Their bladders are so full that literally they can stand up out of a seated position in a chair and they leak urine. It's typically, again, little bits of urine. So you have to distinguish this from the stress incontinence. But again, you need to know that, and an easy way to assess that is to have patients void, and then either do an ultrasound measurement of what's left in their bladder after they void, or you can stick a catheter in to measure how much is left. That one, again, is typically what's called a neurogenic bladder, and again, you have to be very cautious in how you treat those patients.
Very good. And correct me if I'm wrong, I may have said this kind of led you to that functional medicine integrative down that pathway. I think partly it was getting to our next topic, the ways to treat it. So I think maybe this opened your eyes that besides surgery, besides medications, you kind of realized this, along with a lot of other conditions, there's other methods. And I think that probably got you spinning and thinking, if this is this way in urinary incontinence, maybe it's this way in other things. And so when I said this led you down that path to the integrative, it kind of was probably like kind of one of those guiding ways. So if you want to now talk about different treatment options, obviously surgery, you had mentioned, is an option, maybe not always the best, and then medications, but as you'll discuss, I know that you have other ways to treat as well.
No, that's a great point, and you're right. Again, this was my my leading pathway to what I do now. I still practice. Again, I'm board certified in urogynecology, so I still offer treatment for urgency incontinence, stress incontinence, mixed incontinence, and even overflow incontinence in the practice. I don't do as much of that now because I have patients coming in for all these other really complicated issues that we'll talk about in future videos. But no, I mean, even how I treat these kind of incontinence episodes has changed because of what I now know in integrative medicine. So I mentioned surgery, and again, I certainly have performed a lot of these surgeries in the past, but it was literally about 12 years ago where I was introduced to a therapy called pelvic floor therapy with what we call functional electrical stimulation. And I want to save that because I'm going to talk about that as we get down the path as far as treatment options, because that really has become my favorite. Having said that, again, if we look at if there are surgical options, the other side would be medicines. And again, in traditional medicine, they'll offer you, again, prescriptive pills to help with this. Classically, there are two main categories of medications. The antimuscarinics are things like oxybutynin, tolterodine. The problem with those medications now, and this is really some relatively new data, there appears to be an increased risk for dementia in using these medications, and it appears to be additive. And again, I certainly wish we had known that in the past. We now know that at present. I haven't prescribed these for over a decade now because, again, I'm trying to get patients away from a pill or prescription that they're sort of leashed to. Now, there are some other prescriptives that don't carry that same risk that are available. One of them is for the bladder to fill better so that you're able to hold more urine, much better for the urgency side of incontinence. Almost all the pills are really on the side of urgency incontinence, not stress incontinence. The problem with it is that it can, in some people, exacerbate high blood pressure. And so you have to start at a low dose, work your way up. It was really costly before. I think the coverage is better now, so it is a reasonable option, but you have to really be careful with the hypertension side of this. There's a newer one out now, but it actually does not carry the same risk for hypertension. So again, a newer one that actually for some people could be very helpful. If I look at, and I'll age myself here, there's a really interesting medication that had been used in the past as an antidepressant at much higher dosages. It's called tofranil. At lower dosages, 25 milligrams typically is all you need, was actually very good at helping patients with both urgency and stress incontinence. In other words, they have mixed incontinence. It actually could help both. So that's kind of what we currently have as far as the therapy by way of medication and surgery. And again, I know you're going to ask me about, are there any other possible...
You took the words out of my mouth. It's like we planned this talk or spent some time deliberating. But yes, so we can get to that. So ultimately, we have a lot of patients here. They want to come in, they want to get to the root cause. Like you said, they don't want to be tied to a medication. Some people, it works well. Again, we're not anti-medication here, but we want to find ways to get to the root cause. And that's the whole idea about integrative functional medicine, is that can we find ways to integrate other things to get to the root cause? And so surgery, again, isn't always a great option. Medications aren't always a great option for specific people. And in those patients, what are the other therapies? So as you were kind of leading into earlier, but
no, great question. And again, it's really important. And what we typically do is that we do a full assessment. If we have patients who, again, go back to the patient who is not emptying her bladder, she has overflow incontinence, those patients are at significant risk for recurrent urinary tract infections. So we have to rule out recurrent urinary tract infections because those will absolutely lead to incontinence. And that's sometimes in an older individual what their symptom is going to be. When you're younger, it's I burn when I urinate and I may have frequency urgency. When you get older, your only symptom may be, interestingly enough, not only that I've got, meaning a symptom of a bladder infection, that I've got incontinence, but But you have to start looking at people who start to develop some delirium or some dementia type symptoms, because urinary tract infections are a big driver for that symptom. So again, doing a full assessment on these patients, including, most of the time a pelvic examination to assess for, is there prolapse? Are there masses or other potential causes for this particular problem? You need to look at that. One of the most simple things that I did, and I learned this in my residency many moons ago, that really worked quite well, is something called timed voiding. And this doesn't cost patients anything. They literally, and what I'll typically do is I'll get a urinary voiding diary on them, where I keep track of what are the liquids that they take in, the type, the amount, and when they go to the bathroom, how much they go and at what times. And usually I can get an idea of, okay, if I'm having leakage episodes at, let's say, every 2 hours or so, then what we may do is to have them, when they wake up in the morning. Now, you don't do this while you're sleeping at nighttime, but when they wake up in the morning, they go to the bathroom. And then they have, again, everybody's got their watch now that has or their phone that can time for them. Every hour and a half, whether you feel like you need to go or not, go to the bathroom, urinate. Now, if you feel like you have to go before you get to the hour and a half, you try to hold it as much as you can, because I'm trying to imprint in my brain that I'm going to go every hour and a half. If you do that and you can get through the day and not have any leakage episodes for about 2 or 3 days, then you bump it up to every 2 hours. Again, get through about 2 to 3 days, no leakage, then 2.5. Most people void at about every 3 hours during the day. So if you can get patients up to that level, sometimes with some of the medicines that we talked about and or some of what we're going to talk about as far as alternative therapies, that can be very effective.
Very, very good. And it's easy for us to say, right, hold it, wait an hour and a half. I know, because we see these patients, it's not as easy as it sounds. So we get that. Can you kind of tell us about, and you would kind of led on to that, the PT&S therapy that you were getting at?
So the implant that I used to do is an actual implant that would be surgically placed, but there is an alternative with something called a percutaneous tibial nerve stimulation. And so it's actually, interestingly enough, it's almost like an acupuncture needle that you place down kind of in the ankle area, right next to the tibial nerve. And if you actually can do an electrical stimulation at a specific frequency to that nerve, it actually can quiet down bladder overactivity. What we would classically do is the patients would come into the office. We would test that to see, do we have the right nerve to stimulate? We would then have them kind of put their foot up on a little stool, and we would stimulate them for about 20-30 minutes or so. Usually we would do a series of those in a row, and then we would go to maybe once a week or more as far as treatments, and then we could oftentimes space those out for patients. But that therapy is actually quite good at helping with the overactive bladder component.
And then I'm sure the one that a lot of people see, there's a lot of physical therapy now providing this, and that goes into pelvic floor therapy. And if you could tell us a little bit about that as well.
Well, and that's interesting too, because again, I do have a lot of patients even that come see me that say, well, hey, doc, I've already done the pelvic floor therapy. Well, sort of, because the physical therapists are very good at doing their therapy. And oftentimes what they will do is, believe it or not, it's almost like a deep massage type therapy, because a lot of what causes problems in the muscles of the pelvic floor that help us to control whether we leak urine or not, or frankly, whether we can hold urine or not, we will get scar tissue in that, especially ladies who've had kids will get scar tissue within that. Well, they found that through deep massage, we can break up some of those scars so that the muscle units will contract appropriately. What's interesting is that even with that massage therapy, you will create in those patients what's called a neovascularization. They'll get new blood vessels, bringing more oxygen, again, the ability to get a better contraction and control of those pelvic floor muscles. Honestly, a lot of people, though, will do a process called biofeedback. The downside to that therapy, at least from what I've seen, because we used to do something similar, is that there's not a lot of longevity to it. In other words, patients may get some better, but it just doesn't last very long. And so we've kind of abandoned that approach, because it just, again, my goal is to try to get patients better, and so they stay better.
So how does our protocol for pelvic floor therapy work for patients?
So it's a little bit different. Great question. What we typically do now, and again, this is what I learned 12 years ago, there's a couple of probes that we use. So we'll do a physical exam to assess the pelvic floor musculature. Because again, it's interesting. Let me back up a little bit. When we are about 2 years old, we learn to potty train. Because before we potty train, our brain is set up with an ability to sense from the bladder by nerves in the bladder. As the bladder starts to fill, it stretches those muscles. There's a point in the mid part of our brain called the micturition center where once it stretches to a certain point, it will reflexively squeeze to empty. That's why babies have to have diapers. But at about age 2, we start to learn, oh, I can now feel, I sense the fact that my bladder is getting full. And without thinking about it, we actually will contract our pelvic floor muscles, and the contraction of those muscles shuts off that reflex to squeeze the bladder empty. And that same muscle can also kink the tube that drains the bladder when you cough or you sneeze. And so the neat thing about addressing the pelvic floor muscles, this is really where the continence mechanism is controlled. So what we do is we have patients come into the office. We have a probe that's about the size of my thumb that will rest inside the vagina. In the vagina, it will measure what is the activity of the pelvic floor muscles at rest. That activity measurement then allows us to do a specific form of electrical stimulation to those muscles, and this is the key. Now, the electrical stimulation, it does not hurt. There's no risk to the patient. What it's doing is it's causing contraction to the muscle, though. And again, we will set the type of contraction specifically to each patient as they come in, and that's why this works so well. We have another smaller probe that rests just inside the rectum, and we'll have patients do what's called a Kegel exercise or a pelvic floor muscle contraction. Well, we can measure from that, it's called a manometer, how strong is their contraction, how long can they hold that contraction, and then how many contractions in a row before the muscles fatigue. The beauty of that measurement is, okay, we've done the stimulation. I tell people that's like turning the engine to the car on. This is going to allow the muscles to start to respond and recover. But then we know exactly what set of exercises to have the patients go home with, meaning to try to push their muscles to gain in strength, endurance, and stamina, because that's the goal. What we typically do then is we will see the patients back in follow-up. We're now moving to having them do stimulation at home, which makes it much, much easier for the patient. And so we don't have to see them as often, but what we can do is do the manometry measurement and start recording, wow, look at the muscle strength improvement, endurance, and stamina. And there will be a threshold that they meet where they finally say, wow, doc, I'm not having my symptoms anymore. And I'll tell you, again, we've been doing this for 12 years. This was really my foray out of the operating room and into the office for treatment, because ethically, how do I take somebody to the operating room if I have something that's much easier for them, it's less expensive, and frankly, as effective as surgery oftentimes, but without the risk. And so we have seen in the 12 years that we've been doing this about an 80% improvement or better in over 90% of the patients that we've done this treatment. And so the thing I like about this is that, again, it is personalized care. It gets to what really is the mechanism for controlling continence in patients. And again, we just have had really good results.
Yeah, well, it's a lot of really, really good information. I hope that you all got something from this. I'm sure you did. Dr. Roberts and I are very excited moving forward to continue these videos. Try to not make them forever long so that you can get a good takeaway in as short amount of time as possible. But we have a lot of really cool videos coming, a lot of really interesting topics, and kind of just, again, going to the next step in a lot of those. So I don't know if you have any other parting words, anything else you'd like to say, but besides, I know you're excited. I'm very excited as we continue to go forward.
I think, again, I would echo that. I think in integrative medicine, there are so many things that patients have as options to treat, many of the fairly common, and we see a lot of very uncommon things or things that a lot of patients don't get answers for in other places. And again, we just, in all humility, we just are where God wants us in this, and we want to give people information because information is power. And again, we look forward to seeing you in the upcoming series, and we hope to at some point down the road have maybe even a frequently asked questions, or again have people sort of send emails to us so that we can actually have episodes where we just answer questions. Again, thank you so much for being here today.
Thank you.